Hi guys, Sean Allen here. We're back for another episode of the Gait Guys podcast. We're going to have Ivo over here in just a moment, just to do some house cleaning here. Thegateguys.com. Some people are still not aware that that site is up. We're still running the Tumblr site, the Tumblr blog site where we started things 6 years ago. But we've migrated everything over to thegateguys.com. Now there's, I think, 10,000 or so or more people over on the Tumblr site with RSS feed into that. So we're not going to take that down. We'll use that as a backup. But make sure you link into everything over at thegateguys.com for all of your most up-to-date stuff. And as always, we post over on most of the social media sites there, from Facebook, Twitter, YouTube, soon to have Instagram, maybe Snapchat. And we're trying to figure out where we can fit into that app and world of stuff, but we'll see. Anyways, got a couple other things in the hopper coming up, which is exciting, but that will be for another time. And so just a reminder, I know I mentioned on the last podcast, South Loop CrossFit, I did a podcast with Todd over there, and that has not been launched yet, but as soon as it is, we will put it up on our site, the link, plus over on social media. Had a nice talk with Todd, some rather in-depth concepts and discussions on some things that are near and dear to my heart, as well as Todd. So we had a great talk. And then last Friday, let's see, somewhere around the 15th, I think, of October, or now October the 19th today. We did a nice talk with Tina Muir over at Run to the Top podcast, and she is with Runners Connect, which is one of the largest runners communities out there in the world. And so we reached a lot of people with that, or we will be anyways, and we had a really nice talk with her. We talked about some really near and dear to our heart concepts. Tina really brought out some great questions and made us think, and it really was a good time. It was one of the fastest hours I've had in a podcast go by, so we had a great time, and we hope to do more with Tina. So make sure you check out her podcast, Run to the Top, and join up at Runners Connect, a huge community, I think over 60,000 people or something like that, or maybe that's the download, so I'm not sure, but she's got a huge podcast and a huge following, so make sure you check in with that if you're a runner. You'll probably find some useful stuff over there, so keep up with her. And, my personal website, thought I'd give this a little plug, seanallen.net, is finally up. I've written some articles over there, just some personal things that come to mind. I wrote one on concussions called The Boys of Fall, and a couple other things. I wrote one on my perspectives on fighting children's fights in schoolyards and maybe how that's changed social culture. Just some insights in life, on death and living and getting stuff done. I'll have some of my art over there, and I'm going to be doing a series of sketches and paintings on motion and movement and stuff like that. I've got some ideas on Olympic lifts and crawling and lifting and climbing. Just some ideas in my head spiraling around there with ways to put motion into art. So I'll have that stuff over on my website. So in case you're interested, that stuff will be for sale. I do 1 or 2 pieces a month, so we'll see. Anyways, also my office site, drallen.co, and Ivo's is Summit Chiro and Rehab, summitchiroandrehab.com. And one more thing, Ivo's got a acupuncture and dry needling seminar coming up in November. Make sure you check that out if you're looking to upgrade that and get some CMEs and add a new little modality to your adjunctive care for your clients. So no commercials today. I found an article, though, that I thought I would put up. Ivan and I didn't get to this before we recorded. This one's out of Science News, and October 2016, out of the University of Florida. Exercise releases a hormone that helps shed and prevent fat. So kind of an interesting study. University of Florida health researchers learned how the hormone irisin, or irisin, depending on how you pronounce it or like to pronounce it, helps convert calorie-storing white fat cells into brown fat cells that burn energy. It surges when the heart and other muscles are exerted, inhibiting the formation of fatty tissue, according to the researchers. This was out of the American Journal of Physiology, Endocrinology, and Metabolism, and it showed that basically it was an attractive target for fighting obesity and diabetes. according to these researchers. And this is kind of important. It's one of the first studies of its kind to show the mechanisms of irisin's effect on human fat tissue and fat cells. So this hormone appears to work by boosting the activity of genes and a protein that's crucial for turning white fat cells into brown fat cells. And it increases the amount of energy used by those cells, which indicates its role in burning fat. So let's see, what else did they find here? They took 28 patients in this study, and they basically did some fat culturing, fat tissue culturing, and found that the irisin has a positive effect by turning white fat into brown fat, and it increases the body's fat burning ability. So this is huge if you've got diabetes, you've got some unstable blood sugar problems. So let's see. So if you go into this study, you'll find a couple other things. This study here builds on a 2015 study on irisin's beneficial effects. And in that 2015 study, they found that the hormone helps improve heart function in many ways, including boosting calcium levels, which, as we know, are very critical for heart contraction. So real good study, important stuff, first of its kind, and there's going to be probably a lot more coming down the pipeline. Usually when a study like this comes out, everybody else jumps on the bandwagon and starts looking at this a little bit more importantly. So really kind of neat. So get out there and exercise, get moving several times a week, push the heart rates a little bit here. Try not to get too dragged out into your baseline endurance junk miles. I got a lot of runners, and these guys are just moving forward all the time. There's no side-to-side frontal plane motions. There's not a lot of axial stuff. And as we've said here many times on the podcast, runners tend to get themselves into trouble. They don't develop enough lateral stability and rotational stability. And we've put some stuff on our site, our website and social media just in the last week on the metabolic costs of crossover gait, and that there is some metabolic necessity and creation and need for stabilizing that frontal plane, and endurance runners tend to fatigue that frontal plane out, and when they do, that starts driving into the crossover gait, narrow step width, and all of the things that come along with not stacking the foot and the knee underneath the hip on top of a stable pelvis and spine, and that leads to a lot of the hip and spine and knee problems that we see, and certainly leads to inability to control the rotational loads down and through the foot, and can lead to the pronatory issues that we see from whatever improper loading of the first ray, big toe, sesamoiditis, overpronation, stress fractures, tib posterior tendinitis, gutter syndromes, synovial impingement, Achilles tendinopathy. The list just goes on and on and on. So make sure you guys are out there training in multiple planes. It's critical. It's absolutely important. And just running all the time is not a nice varied exercise, and it's going to lead to some problems most likely. And that's why runners tend to break down later in the runs, because they've fatigued out the musculature that they do have that stabilizes the frontal and rotational plane. I think it's why I see so many runners with hip problems. But anyways, off that soapbox, we've got a great show lined up for you today. No commercials, as I said. We're just going to go right into the show. Put on your favorite ear cans. Let's get going here, guys. Right, Ivo, we are here for number 113, and got a neat little itinerary here, but we got some cases that we probably can banter on about and have some open dialogue. Folks seem to like these ones. So, but let's start with this first one. This is one that you had put in there a while back, and it'd probably be something you can just talk, off the top of your head about, because this is right up your alley. But this one's called "Lifelong Strength Training Mitigates the Age-Related Decline in Efferent Drive." This was in the Journal of Applied Physiology 2016. First of all, why don't you talk about what's that title mean? What are they talking about?
What they're looking at is we have two main systems in the nervous system. We have afferent, which is sensory information coming in, an efferent or efferent, which is basically motor information going out. And the motor can be either autonomic, driving your, heart, lungs, those sorts of things, or it can be motor like skeletal motor, like we often have a tendency to think about. So with this particular one is looking at skeletal motor drive. And the main reason we put it in is because we get a lot of questions about training. It's like, what's the carryover? What's the longevity? And here's a study that really makes a argument for training for an entire lifetime. And what they did is they looked at three different groups. They looked at this group called strength-trained master athletes. In other words, people that have been training a long period of time. They looked at another group, the beer and Twinkies group, the sedentary group. And then the recreationally active people. In other words, people that like, well, I'm active, but they don't necessarily strength train specifically. And then finally, a young group, which was considerably younger. So they were comparing elderly people in their 70s, plus or minus 4 years, to an extremely young group, 22 years plus or minus 2 years. And the long and the short of it is that the people that had been strength training their entire life had results which were similar to or better than the very, very young people as far as measuring this efferent drive. And they used EMG. They looked at things like maximal voluntary contraction, V waves. They also looked at H reflexes, which is sort of an electronic ankle reflex. It was really neat. The conclusion, the observation suggests that a lifelong strength training has a protective effect against age-related attenuation of the efferent drive. So in other words, as we age, a lot of times we see that decreased drive. And some people thought maybe it was testosterone levels, some thought maybe that it was neurally related, and a lot of it is neurally related. And the other interesting conclusion of the study was no beneficial effect seems to derive from habitually recreational active people. So the strength training itself, in and of itself, you got to get down, you got to do it. You have to be out doing things that are going to make it work for folks so that you can go on and live to be a healthy, ripe old age and hopefully be running. I'm planning on running and mountain biking and skiing well into my 80s and 90s. So you have to be out doing that actual strength training things, whether that's squats, whether it's lunges, whether it's, burpees or CrossFit or whatever your particular cup of tea was. So again, just an argument for doing that lifelong training.
Yeah, it's just all about staying active. And I thought I would throw this one in here as a follow-up to that. This one's on telomeres and aging. And this one was in the Well blog, New York Times, and we'll have that in the show notes for you. But they preface the study by saying, today many scientists have begun determining a cell's biological age, meaning how well it functions and not how old it literally is, by measuring the length of its telomeres. Now, for those of you guys who are maybe living under a rock or perhaps just not into science reading, the telomeres are the ends of the DNA strands. They're like these little plastic thingy-mid-doodles on the end of shoelaces, if you will, to keep them from fraying. And DNA does that too, and it's going through cell division and replication. So they looked at these telomeres, and they were able to define a couple things in the study. And so here's what they did. They took some people, and they had them engage in 4 activities. They gave them a questionnaire, and they said, if at any time during the last month you've been engaged in weight training, moderate exercise like walking, more vigorous exercise like running, or have walked or ridden a bike to work or school. So weight training, walking, vigorous exercise like running, or I guess you could throw biking or something in there, more aggressive stuff, and then basically some more sustained kind of moderate bike riding. And they took those folks and they gave them a questionnaire. And they basically said, and here's how they kind of went through this. Specifically, someone who participated in a single activity earned them a 1. And that earning them a 1 was about 3% less likely to have short telomeres than someone who didn't exercise at all. That risk declined more substantially if someone exercised more. So the people who reported 2 types of those exercises were, get this, 24% less likely to have short telomeres. 3 types of exercise, in other words, checking off 3 boxes on those 4 exercises that I mentioned, were 29% less likely. And here's the big jump. Those that participated in all 4 of those activities were 59% less likely to have very short telomeres. Now, the study goes on to say that, interestingly, these associations were strongest among people between the ages of 40 and 65. They suggested that middle age may be the key time, between 40 and 65, to begin maintaining an exercise program if you wish to keep these telomeres from shrinking. Now, this study is purely associational, as the authors had suggested, so it cannot show whether the exercise actually causes changes in telomere length, only that people who exercise longer have longer, or exercise more have longer telomeres. So, and as they say here, perhaps most important, the results don't tell us whether longer telomeres translate into better health, but have shown that telomeres are predictive of mortality. So telomeres are a nice little gauge, and they're not predictive, but they certainly are suggestive. And so it's suggested here that making several different types of activity part of your weekly basis, and maybe even multiple types on a daily basis, will certainly expedite aging, or slowing the aging process. And there's been more of this even in the last week on exercise and preventing cancer and whatnot. So it's very evident that staying moving and incorporating low level to high level to sustained low level to short term high intensity stuff, including weight training and maybe even high intensity interval work, certainly is going to help you stave off cancers and whatnot, at least according to most recent research, and maybe even keeping the telomeres from shortening and fraying. So, anything from you on telomeres?
You know, we do telomere testing in the office. It's like you said, it can be a good sort of snapshot benchmark. It doesn't tell you necessarily what you need to do, but it tells you that you need to do something different if your telomeres are shortening. The interesting thing is that with appropriate dietary changes, at least, I've read research on that, but I'm sure exercise has an effect as well, you can actually start to lengthen them again. And that, of course, will increase your ability to repair your DNA. So, interesting stuff. You know,
how do you test it in your office?
We use a couple different labs, predominantly Cell Science, but there's some other ones. It's a blood test.
It's a blood test, okay.
You know, we do the draw, it comes out, and it gives you like a readout as far as which ones, you know, where you're at and what we would expect to be normal for your age, and things like that. It's more of a wake-up call for people.
Yeah.
And, you know, to some degree, if you look at some of the literature that's out there, it talks about it's, you know, longer telomeres are linked to longevity. Mm-hmm. So it's a pretty easy sell if you've got somebody that's kind of on a bad diet and not exercising enough, and you do a telomere test and they see that, gosh, I'm, you know, 50% of where I should be or where I'm expected to be. I really need to clean up my act if I want to be here much longer.
Yeah.
So,
and if you throw in obesity, smoking, insomnia, diabetes, those types of things, that's certainly going to expedite the process. So it really comes down to taking care of yourself. And if you're not doing it, you're going to get called out. Your day of reckoning will very likely come soon. Now, there are those folks. There are those folks that get away with it and they're smoking in their 90s, but those people are outliers, and you shouldn't be really comparing yourself to those folks. So in previous podcasts, at least recently, we've been talking a lot about virtual reality and artificial intelligence. And this one in The Guardian, I thought, was interesting. They're basically, we're following on our trend that virtual reality is going to be a mainstay and a staple in a lot of things, but certainly in rehabilitation. And in this case, this study looked at 8 paraplegics, some of them paralyzed for more than a decade by severe spinal cord injury. And they actually used virtual reality in combination with harnesses and other walking aids to get the patients accustomed to making a link between movement and thinking about movement. And that seemed to be the key. Movement, thinking about movement, and then putting them into a scenario where they actually are in a virtual reality type situation where they're actually seeing the feet moving, they're seeing the world moving underneath them as if they were walking. And there was some rather startling results in this study. After just 10 months, a lot of these folks who had been fully considered paralyzed have been able to make conscious decisions to move and then get a response from muscles that they've not been able to move for a decade. And some of them even more so. There was some huge differences in some of these folks. Where were the results here? Let's see. Gradually, at different rates, they began to experience voluntary muscle function below the injury. They went from total absence of touch sensation to the capacity to sense pain, pressure, and vibration, though not temperature. Gastrointestinal function improved, and those who spent some time upright and walking saw the most improvement in bowel control. Men reported experiencing erections, and all had been diagnosed as cases of complete paralysis. Since the training, some of them had been reclassified as partially paralyzed. So very interesting. We've talked previously about using stem cells and electrical stimulation devices, and basically these folks are learning to reinterpret the sensations and movements of gait through skin reception on the forearm and then reinterpreting it up into the brain. And so this is getting very interesting, and it seems like every week that goes by, or at least every 2 or 3 weeks that goes by, there are studies coming out that are showing some rather dramatic improvements in getting folks, and at least the ones that are challenged from a paralytic standpoint, major changes. Any thoughts on this guy?
A couple interesting things about the study. Number one, in this particular individual, in this particular study, demonstrates the importance of afferent feedback, and not just tactile, but also visual. When you're in a VR situation, you're going to get input, and the brain is going to think that certain things are happening, and as a result of it thinking that certain things are happening, it's going to change the neurological pathways which are involved with that. So the afferent feedback is extremely important in these individuals, and the fact that it's sort of like, reality. You think of the movie Avatar, where the guy was basically a diplegic, and he was in the machine, and all of a sudden now he's able to do all of these other things that he couldn't do before. Just being able to do that, and the fact that that's being translated back to real life is absolutely huge and amazing. So I thought that was kind of the coolest thing about it. But I really think it's the feedback that's being provided. And it just goes to show that looking at the afferent side of the nervous system is probably really where it's at. If you think about a lot of healthcare today, it focuses on efferent pathology. It's looking at the motor or the outcome, the end organ, rather than looking at what's coming in. Afferent not only includes sensory stuff, but you're also thinking about, food, air, breathing, all those other things. And if you start to look at those, you start to realize that that's going to influence efferent so much more than just working on the other end. So getting it before it goes through the system and making a change there, as opposed to waiting till the output of the system, you can really affect outcomes through the thousands of synapses that typical information will travel through in the nervous system. And this just shows the diversity of what we're actually able to accomplish. Pretty cool stuff.
Yeah, I thought so. Definitely. So earlier this week, or maybe it was last week, you had some very interesting posts up. One of them was on hip extension and the importance of hip extension, and getting to that near terminal end range, especially in gait, whether it's running, walking, and having some existing weakness at that terminal range certainly isn't going to give you stability at the hip joint nor power at that end range. And so you're going to start to kind of back away from that end range because you can't, one, produce power, you can't protect the joint. And if it's not there, there's no point in using it. The problem is as you start backing away from hip extension, if the glute is weak, you start backing away from ankle dorsiflexion. And I recently had a fella come into the office, and he's a very high-level masters triathlete, does very well, but he has ankles like bricks. He barely, on a good day if he's lucky, gets 90 degrees ankle dorsiflexion.
You mean zero?
Zero. Yeah, zero. I mean, he's perpendicular. You can't get that tibia past vertical. And so, obviously, if he's to move forward past that, he's going to go into premature heel rise. And his biggest complaint is that he just keeps blowing up his calves. They're just always tight. They always feel like they're going to explode after a long run. They're just so tight and so overworked. And obviously without any, relatively any ankle dorsiflexion, his hip extension stinks. You get him into a bridge and he's trembling at, basically a neutral pelvic tilt in a reasonable amount of hip bridging. Certainly there is no hip extension in his bridge, and his bridge exists of mostly lumbar extension, and he's grabbing at his hamstrings all the time because he can't get into his glute in the bridge position. And, we had a long talk with him today about, look, we've got to work on winning both ankle dorsiflexion and hip extension because these two are tied together. And so you had some posts on here, including the one that just, kind of blew up, the one on the Z angle, and there was one on basically just basic hip extension stuff. What were you trying to hit home on that stuff? And did you have just some dialogues you wanted to throw out there, or on my case that I just discussed?
I just think hip extension and ankle dorsiflexion are so overlooked, and that's one of the reasons that I put up some stuff. It started several weeks ago. We're recording this on September 9th, but this was actually back in mid-August, where there was an interesting article about K-tape improving hip extension in athletes. It was a lower extremity review article. And we put that up, and then people really seemed to dig that. So I started digging in deeper as I was looking at some other stuff for some patients and came across a series of different articles. So I just started posting some of those. But the Z angle is something you and I have been talking about for years. As far as, and basically, for those that haven't read the article, we encourage you to go back to either our Tumblr blog or back over our Facebook posts, from that time frame, and look for the one on the Z angle. I think if you put in the Gait Guy Z angle, it'll come up for you. But we're talking about ankle dorsiflexion pretty much trying to equal or exceed hip extension, and it's really important for those two things to be symmetrical between the two. And if you kind of think about one and the other, and you look at the line of the extremity, it kind of makes a backwards letter Z, which is where we got the idea. There's nothing in the literature necessarily that talks about the Z angle per se, but there is a lot of stuff in the literature that talks about the importance of hip extension and the importance of ankle dorsiflexion that go along with that. One paper that comes to mind, it's a full text. I'm not sure if I put it up. It was a paper done in Medical Journal of Islamic Republic of Iran, of all places. But the title was Comparison of Spinal Curves and Hip, Ankle, and Ankle Ranges of Motions Between Old and Young Persons. And it talked about the relation of those two. And that article was from 2014. There was another one looking at, it was by Kara Lewis, not Carl Lewitt, but Kara Lewis, and this was out of Journal of Biomechanics 2008, looking at increasing ankle push-off. And if you think about increasing ankle push-off, that's basically increasing plantar flexion of the ankle, decreasing ankle rocker. And the title is Walking with Increased Ankle Push-Off Decreases Hip Muscle Moments, in other words, hip extension. And both of the articles are good, not simply because they're good articles, but because there's so many great references within them talking about the stuff. And that's what I have to say, when I'm reading, that's like my favorite thing to do, is to look through the references. Probably most of the time, even more so than the article. Because it's like, oh, I really needed a reference, for this particular, theory or whatever, and there it is. But those two things are important, and if you're lacking in one or the other, you're going to try to make up for it in one or the other. Like if you're lacking hip extension, then maybe you're going to increase your lumbar lordosis, or maybe you're going to try to increase ankle dorsiflexion. If you can't do that, you're going to pronate more through the midfoot, or things along those lines. But it's just such an important concept, and it's such a simple thing to check. We need a requisite, and this is you and I. This isn't the world says out there, but you and I have found clinically that people that have less than 10 degrees of hip extension and less than 10 degrees of ankle dorsiflexion tend to be more symptomatic. 15 is sort of the ideal, even though 40 is like, if you look in Hoppenfeld, what the value should be. But I haven't really seen too many people that have that kind of a range of motion. And when people become less than that, that's when they tend to have symptomatology. And I've looked for numbers in the literature, and I'm always looking about like what, exactly how much, what have they found? And I haven't found a paper yet that talks about that, but they do talk about decreases, statistically significant decreases in one or the other, that one affects the other. and that these things can be tied to a constellation of problems. And I mean, I'm sure you have a million stories, and I can't tell you how many cases of plantar fasciitis and metatarsalgia and knee pain and people with lower back pain, et cetera, have a lack of either one or both of these factors. And you go in and you increase those amounts, possibly with exercise, manipulation, dry needling, acupuncture, whatever your modality of treatment is. Or you just teach them that range of motion that they didn't know that they had, and all of a sudden they get better, like dramatically better, pretty quickly too.
Yeah, it was a very interesting dialogue that I had with this gentleman. We've been talking about it over several treatments because he's really interested in understanding why he has these problems. And, we got into the discussion of, is it the lack of ankle rocker that started it, that caused the lack of hip extension and the glute weakness, and thus the shortening of his strides, the higher cadence that's necessary, the lack of power when he has to, start into some speed work. He just can't seem to speed up because he doesn't have that hip extension and glute push off. And then we discussed, well, maybe it's the lack of hip extension and the weak glutes that's driving the ankle and, acting as the governor and slowing that down. But regardless, in his case, and this caused me to, just as I was waiting for you to get on the phone here, to look in Michaud's book, Human Locomotion, which we recommend to everybody, just to look at the time signature for the gastroc and the soleus. And if you go into his work on muscle function, the summary of muscle function during the Gait cycle, and if you're into your book and it's in front of you, or you can remember to jot this down, it's on page 132 of his book, 131, excuse me. You look at the actual time signature, the actual EMG firing of the gastroc soleus, and the high-end burst. Now, there is a low-end burst from basically forefoot loading through to heel lift, but the biggest burst is of the gastroc and soleus, and the soleus is just before the gastroc, is right at heel lift. So as you're getting to that end range of ankle dorsiflexion and you're just about to get into heel rise, obviously the gastroc and soleus are going to start to fire there. And so obviously you want to go back then and look at the time signature of the gluteus maximus. And, as it just starts to tail off, that's when you actually see the gastroc and the soleus starting to kick in. So it's kind of a 1-2 punch. Glutes first, then into your gastroc and soleus. Those are your forward sagittal plane propulsive movements, or muscles, excuse me. And so it was no coincidence that he was just as he was getting into his gait stride, and he was losing the ability to get to his glutes because he was getting into that range where he didn't have enough hip extension. He had to move forward somehow. He was doing a lot of it from forward lean, but obviously he was using his gastrocs. And the problem was, why were these gastrocs getting so sore and blown up and tight and just killing him by the end of a run and then paying for it for days afterwards? Well, when the gastroc has to fire early, which in his case it's firing earlier than heel rise because his heel rises is premature compared to normal. His gastroc is lifting his whole body mass up, is my suspicion. The gastroc is supposed to hopefully wait until you rock off that heel, getting into ankle rocker and into forefoot, and then you really fire that gastroc to propulse you forward, stabilizing the ankle as well. In his case, he's not even close to that phase, so his gastroc is firing earlier, and when it fires earlier, you're going to get even more premature heel rise, so you're going to get a vertical phenomenon. So he's lifting more body weight up than pushing body weight forward. So that's one of the theories that I like to talk about with my clients. Whether or not that has some roots to it and some legs to it, I don't know. But I'd love to hear your thoughts on that, because in patients who do have lack of ankle dorsiflexion or lack of hip extension, we do see this chronic calf tightness. And no matter how much you do windshield wipers and anterior compartment work in that shin, it's really hard for these folks to get out of that chronic gastroc tightness, soreness, overwork.
I think you kind of talked about all of it as far as what's going on. Those are the major factors. Of course, there's other ones. How is he initiating hip flexion? Are his muscles firing in the correct temporal sequence? Is he substituting his lumbar erectors and his hamstrings for hip extension? In substitution for his glute, you're supposed to get that blast of the G-max as soon as the heel hits the ground, and then again, right at push-off like you were talking about. Mm-hmm. But, Yeah, you see this a lot, particularly in people with apropulsive gait. And if you think of it purely from a physics standpoint, think of like a framing square that carpenters use, and think of the ankle-foot complex as that framing square, and it's not going beyond that 90 degrees. If you're stuck at 90 and you still need to go forward, the only place you can go is up. Yeah. And at that point, the only thing that's going to take you up are, the gastroc soleus group, or if you think about it, the foot intrinsics.
Yeah, long toe flexors,
the long toe flexors, and maybe some of the short ones are going to assist, in that supinatory movement there. Mm-hmm. But those are the only things that can be active, just from physics.
And you get into hammer toes and everything else.
Right, and then when you start to combine in, they have external tibial torsion. So now they have a poor lever because they're already going to be in, pronation as they start to come through, and the weight's coming off the side rather than through the great toe. Or maybe they have internal tibial torsion. They're coming off the lateral aspect of the foot, and they have that apropulsive, type of gait that's going on there. Right. So, not surprising. And then getting these people to do things. It's like, I need to stretch my calves. Well, yeah, but, the adage of, I think you actually coined the phrase, but you need to gain anterior length through posterior, or posterior length through anterior strength. Yeah. And, it's like work the anterior compartment. Reciprocal inhibition trumps stretching anytime. Mm-hmm. Okay? Stretching is a pure, more of a mechanical phenomena, whereas reciprocal inhibition is a neurological phenomena. And once you start to facilitate that pathway, you start to get all these collateral pathways that are going to sort of conspire with you to increase the range of motion rather than just relying on an external means such as stretching or lengthening or something like that, night splints, And those things can be effective, but only to the effect that the nervous system will allow them to be. So if you change the muscle, it will change to a certain effect. But if you change the nervous system, that's where you make the huge differences there. And you can see it when the bell goes off. And the changes are slow, and I think you'll agree with me. Initially, they're not great gains, but the people have tremendous gains in their symptomatology. Like, they only gain 3 to 5 degrees of dorsiflexion. And they're like, oh my God, I ran my best ever, and I felt so free, and I wasn't sore when I got home. And you're measuring and you're scratching your head and you're saying, wow, like 3 degrees? Okay, good, Yeah. But then later on, those dramatic effects start to taper off, and the people actually get greater gains in their range of motion, but their symptoms change less. And the reason, my belief is, because you're going to see those largest gains, up front first. And the largest changes are going to be the neurological ones, where the physical ones occur later. We've talked about this with exercise lots and lots of times. Neural adaptation, Digby Sales work, all of that stuff. So, yeah, it's amazing. It's truly amazing when you do that with people. And if you opened a practice and those are the only 2 things that you did was increase people's ankle dorsiflexion and increase their hip extension, you would have a very busy, very successful practice.
Yeah.
Because it's so prevalent. Yeah.
It's a big part of practice, and knowing the order and knowing what exercises work for that client. And some folks, you got to focus at the foot and ankle early on. Some of them you got to work on the pelvis, because if you don't have enough hip extension, a lot of folks are just going to dump into anterior pelvic tilt and just, like you said, put it in their low back, and they'll think that's hip extension, whereas it's just lumbar lordosis accentuation or lumbar extension. And maybe at this point, just as a reference to summarize this, is you've got to figure out how to get your center of body mass forward past the ankle axis. And so as you start to put your foot down and your body starts to move up and forward, as long as you can dorsiflex that ankle and get enough hip extension to move the body mass past that foot point on the ground, you're good to go. But as Ivan and I are talking about here, a lot of people don't have those 2 things, hip extension, ankle dorsiflexion. So anterior pelvic tilt and going into the lumbar spine is one. Hyperextending the knees is another. Pronating through the foot is another. Going vertical is another. And it reminds me that we have a video called the 6 compensations to get around an impaired ankle rocker. Go over to YouTube and just type that in. Gait Guys channel on YouTube, just type that in, Gait Guys YouTube channel, and type in 6 compensations, and you should pop right up there. If you have problems, just send us a message and we'll find it for you. But good stuff, and I think very, very valuable. And if you know those two things, like I was said, if you're good at getting hip extension back and you're good at getting ankle rocker, and you know the compensation patterns of maybe turning out the foot or compromising the knee in the frontal plane, if you know all those compensations, I was right. You can really build a practice around just those principles right there. Market yourself to runners, which includes your basketball, your volley, or your soccer, your triathletes, your runners, and just your walkers, if you will, marathoners, etc. So it's a big piece of practice, and if you get that stuff down, you're in good shape.
Yeah, it's huge. It's huge.
Hey, I wanted to before we go any further, I got a question for you. I had this lady come in. This was kind of neat, and it just was kind of a duh moment to me, but she came in and she'd been wearing a Chopat strap, which is basically a counterforce brace around her knee for 2 years, basically walking with it all day, playing tennis with it all day, running with it. So a Chopat strap, for those of you who don't know what it is, or a counterforce brace, it's basically, it looks like a circular tube. Some of them are made of straps with a pad, and it goes around just below the knee, and it creates a false insertion. And so you usually do this when you got patellar tendonitis or Osgood-Schlatt's disease or some type of a tendinopathy where you're getting the forces playing out improperly. I don't like to use them. I let clients use them, but I tell them, look, we got to earn our way out of this because it's a crutch. But she had this thing on so long that she had about a 15-degree, 20-degree loss of terminal knee extension. And the only thing I could think of was that she had compromised the function of that quadriceps for so long and changed its mechanics and lever arm and power and whatnot, the force that it can generate, for so long that she no longer was able to get to the terminal end range because she couldn't use the muscle like it was originally designed, because she had augmented or changed, if you will, the actual insertion point. Have you seen that before?
I have not, but it makes total sense that you're just moving the insertion point more proximal.
Yeah. And
so now when you're asked to use the entire length of the muscle, your sarcomeres are a different length,
Yeah.
So you're gonna be missing some of that. We see people that become accommodated to braces and orthotic devices and things like that, where they'll actually have changes that will occur over time. So I haven't seen that. We've seen the Chopat braces, and like you, we pretty much discourage a lot of those things. Once in a while, tennis elbow braces for manual handling folks. We see a lot of carpenters, a lot of people that are using their hands that need to continue to work and are unable to stop and do what would be, a little bit more appropriate for that tennis elbow. So we may use a tennis elbow brace in that. The other thought too with the Chopat just coming across there is the whole ischemic training thing. And I know you had a couple posts this past week, or actually it was last week, looking at ischemic training, and this may not be like the best thing since sliced bread for gains, and perhaps, because that Chopat, yes, it goes around the tibial tuberosity in the front, but other musculature in the back.
Yeah, hey, let me just dive in just for a sec, because I definitely want to hear what you have to say on this, because this has been something of great interest to me, and I put something up recently on it. Think about this, folks. She has loss of terminal knee extension because of the altered mechanics in that quad. So when you stand and you limit terminal extension, what have you done? You're in relative flexion, right? That leg is slightly shorter now because you're flexing it. So she came in with opposite ankle pain. So this was her left knee. She came in with right foot pain, foot and ankle pain. And so think about it. Her brain is going to say, well, we got a short left leg, so let's supinate that foot. And on the opposite foot, what are you going to do? You're going to try and shorten that leg. So she actually had caved and almost completely collapsed her right foot arch to try and get that leg shorter. And she was trying to lengthen the left leg by, trying to supinate the left foot. And so she came in with tibial posterior tendonitis and some hyperpronatory type mechanisms that, a syndrome, if you will, of, weakness of the plantar intrinsics and some attenuation of the plantar fascia. So she came in with opposite knee pain. And I happened to notice that there was an indentation on the left, right below the knee. And I said, hey, what's that? And she goes, oh, I just took off my brace before you examined me. And I said, why are you doing that? She goes, well, I have to wear a brace, otherwise I get knee pain. I said, how long have you been doing that? Oh, 2 years. And I said, so you just wear it? And she goes, no, I wear it all the time. I wake up in the morning, I put it on, and I take it off to shower. And the first thing I do is, I take it off before I go to bed. But otherwise, it's on all the time. And so it just cued me to look at the quad. And of course, the quad was weak, but she had no knee extension. And that's when I was like, that's probably why you have right foot pain. Had her stand up, and boom, there it was. She was, flexed in the knee and pronating on the other. And she looked like she had a level pelvis because she'd figured out how to get around that by supinating the left foot and pronating the right. But, when you asked her to go into terminal knee extension, she had pain because it was basically contractured there. So it was an interesting case because it required you to actually understand how she was compensating and understand how the brace was actually creating her new problem because it had been used so long. So it actually became more involved other than just the identification of the lack of extension. So I thought that was cool. So.
Well, and piggybacking on that, if her right leg is always in a little bit of flexion, it's going to shorten your hip flexor musculature.
Right.
And if the left side is always in some degree of extension, it's going to create some lengthening of some of that posterior compartment musculature. And away we go with compensation pattern that builds month upon month, year upon year. And those people come in and, you see them, you're like, wow, you're pretty whacked. We need to make some changes here.
Yeah. And remember, someone who has a slightly flexed knee is not going to get into terminal hip extension either, which opens up the whole dialogue we had earlier on today. So
you're going to decrease ankle rocker on that side,
Boom, there you go. I mean, it's all there it is,
because
folks.
of that relative flexion. Yeah, and it's just going to work its way up, and then your step length is altered, and then, it just becomes a big mess.
There's the whole practice thing again, built all around the same principles.
All you need is, I'm going to have that on your card. People have like practice limited to orthodontics, practice limited to hip extension and ankle dorsiflexion.
Yeah.
And people are like, what?
Trust
what
me,
are you talking about?
Yeah,
man?
it's like the upper cervical practitioners, not to bash them, but this is your answer for everything. So, anyways, you were talking about ischemic compression stuff. Where were you going with that?
Oh, I was just saying, because she's had this brace on for a long period of time, it's compressive,
Yeah.
Compressive to the tendon, which is going to cut off blood supply. Compressive to any superficial neurology that's in the area, and compressive to the musculature surrounding particularly the triceps surae. As well as you got to think about the peroneus. So, what are going to be the effects on the peroneus of long-term compression over a long period of time, particularly the longus, which is in that area. Plus, your common peroneal nerve is right in that area. And that subtle compression over a long period of time can alter, exoplasmic flow as well as nerve conduction. So, there's just a whole constellation of things. And we're not saying that using this kind of a brace is the wrong thing to do. We're just saying using it for 2 years might want to clue you in to maybe we should look at a different cause here.
Yeah. Well, that reminds me of did you see the post on the professional yo-yo guy with the hypovascularity?
I did. You preceded one of the other posts that I had done, but, sort of a similar vein. But that was incredible. I actually showed that to a bunch of people in the office. But, yeah, that was pretty cool.
Yeah, and that goes back to that brace. What has she done over a long period of time by choking off that area to some degree? You can stomp on vasculature just a small amount, and over time create a chronic change in tissue distal to the vascular compromise. So something to think about there. But we don't get any professional yo-yo people in my office yet. I haven't broken into that market yet, but I'm hoping to.
You can do it along with your practice limited to hip extension and ankle dorsiflexion on your card, and professional yo-yos, people. All right, so since we're on the subject, we need to go there now.
Okay.
You put this thing in the feed to look at the what's it called? Brace to play above joint ankle brace, and I know you had a post on it talking about that. So why don't you go ahead? Talk about some of the stuff that you had, and then I've got some input after that. But since we're talking about braces, we might as well go there, right?
Yeah, let's go there. So this brace is called what is it called?
Brace to play.
Brace to play. We saw this on one of the sites that we follow regularly, and I immediately had to just, my baloney meter went off the charts when I read this thing and went, okay. Dial back for a minute here, Sean. Everything has a place, and everything can be used to a good point, but you can also use things in the wrong way. And so this thing, they're basically, and when you go into the fine print, I think that if you're educated, you realize that this doesn't, fix everything. But it's basically a compressive brace that goes above the ankle. And they're saying, if you've got ankle problems, you can use this brace and it won't impede motion and it'll fit in the shoe and everything else. But, if it's not crossing the joint, it can't stabilize the joint. Okay? This is a Syndesmosis brace, which is the fibrous ligamentous connection between the distal tibia and fibula, and it holds those two bones together. It also is a slightly forgiving piece of tissue that when you step down and the ankle mortise spreads as you go into ankle dorsiflexion. There's that concept again. Good Lord.
Yeah, there it is, man.
Yep, you have to be able to spread the tibia and the fibula, so they have to accommodate. So the mortise is actually kind of triangular shaped. So when you put your foot on the ground, out in front of you, if you're in heel strike, the back of the mortise, which is the top of the ankle joint, if you will, is very narrow. So the tibia and the fibula, in other words, the width of your ankle between your two ankle bones, if you were, is very minimal. But as you start to move across that foot and then go into heel rise, you're at the front of the ankle mortise and it's wider. So obviously the distal tibia and fibula have to widen. And there's a syndesmosis to say, okay, that's as far as we can widen. And then the ligaments come down off those two bones into the ankle to stabilize the ankle on the inside and outside. And those are the ones that people tend to rip apart when they sprain the ankle, whether it's inversion or eversion. Of course, inversion more common than eversion. This brace goes above the ankle, so it's basically a syndesmosis support. Now, I could make the case, and there's probably no literature out there, but if there was, it would be more of a supposed translation on the reader's part, that if you stabilize the syndesmosis, you might get better function below it. But you're certainly not going to get a change in ligamentous integrity. You can't do that. But you might get better contractile active support below it. It's possible, which might give you the sense of increased security at a torn ankle or torn up ankle inversion, like a lateral ankle complex. So it might give you a false sense of security, and that's one of my bigger concerns with this brace. The other concern is how tight do you crank this thing down? If you crank it down too tight, then you're going to lose ankle dorsiflexion because it's not allowing those two bones to separate. If you put it on too lightly, it's not going to do anything. So it's one of those, is this thing really doing anything? And my God, there's a lot of factors to take into account here. And actually, where is my injury? Is it a syndesmosis injury, meaning a high ankle sprain, or is it down a low ankle sprain, incorporating those lateral ankle ligaments, the anterior talofib ligament and the other ones, the anterior and posterior talofib, etc. So that's kind of where I was going with that thing is, whoa, you got to know what you're buying here. And this splint, I think, was a little misleading in my opinion, but maybe I was looking for it to be. I don't know.
Yeah, one of the things I did is, and then we actually went to their website, and it's a prominent physical therapist that's designed this. But I wasn't able to find any, there's all kinds of stuff on their copyright and their commercial, but nothing about the technology.
Yeah. It was
as far as what's your reasoning behind this? So they said it's backed up by research. It says that right on the website. So I went into PubMed and couldn't find anything about brace to play or anything like that. Now, maybe I wasn't looking in the right spot.
Yeah.
And I didn't research, I'm trying to think of the gentleman's name, Andrew Mirabella, who's the CEO and inventor that's done this. But and I'm not saying the brace is a bad idea. I'm just saying that I want to know what's your thinking and how's your technology working.
Well, if you were selling it to be a syndesmosis support, I have no problem with that.
Right.
But they say
that wasn't the impression I got from the video.
Well, and they even said it treats shin splints. Okay, first anterior or posterior shin splint, or both. But how's it treating it? It might be supporting that compartment, but you're not changing that compartment. You're not improving its function by any means. You may be altering it by compression, but treating it, I think that was a bit of a long shot. Braces, as I said in my post, are supportive and nothing more. So supporting shin splints might have been a more accurate, moniker to put on there rather than saying treat it. But I just again, if you didn't know what you and I know, or a lot of our colleagues that are listening to this know, you might think that this was good for you or your son or your daughter's ankle sprain because it fits better in the shoe. And there's athletes on the site saying that this thing was phenomenal. And I'm like, whoa, okay, well that athlete had something completely different than your kid did. So I don't know. I think they need to do a little bit more education on this one here. But who am I to say? I'm just a chiropractor.
Well, aren't we both?
Yes.
But anyway, I'd like to see a little more research on it and know a little bit more about where they're coming from. Again, we're not saying it's a bad idea. We're just saying that maybe it's being portrayed as something a little different than what it actually is.
Yeah, just be a little bit more clear, that's all. Maybe they will be in time. Maybe we caught them in the early phases. I don't know. I'm willing to give them some credit right now and look at it again down the road. Hopefully they'll listen to our podcast and maybe be a little more clear.
Yeah.
Yep.
So, hey, you had put something up on weak toe grip strength on that. I'm trying to think of which journal it was out of.
Yeah.
Got so many things open here.
That was out of, I'll tell you right now, that was out of, well, that was on Research Gait, but I don't know where they actually ended up publishing that. This is one our friend...
But anyway, where were you going with that? And then I will chime in because I definitely have...
Yeah. Well, Craig Payne, a very intelligent, at least from what I can tell, a podiatrist who runs the podiatry forum on the internet, which is actually quite good, and some very, very wise brains on there from diving into some of their forums. I'd recommend you get on that one. He brought it on his Twitter, and I was like, Craig, I'm going to put that on our Facebook page, and I gave him credit, as I always do, because he was first there. And he said, chicken or the egg. It was all about toe grip strength and weak toe grip strength and correlating it with Hallux valgus. And they were trying to say that in their study, we found that when the toe grip strength was weak, that there was a correlation to Hallux valgus, especially in younger children, particularly females. And as Craig said, chicken or the egg. In other words, which came first? Did the Hallux valgus come first, and that's what's causing the weak toe grip strength? Or did the weak toe grip strength occur first, and that's what caused the Hallux valgus? Chicken or the egg, who knows? But, I think it's far more complicated than that. I'm sure Craig does, and I'm sure you do too. I think it's pretty hard to correlate those two together. But nonetheless, when you do a study and you see them, there's something there, you can correlate them. Whether or not they're predictive or not is another question. Go ahead, go down the rabbit hole here, buddy.
No, I found it, first of all, the study, interesting, as far as that they found that correlation. And again, is it the chicken or the egg? Is it flexor dominance that ultimately created this? In other words, do these people that have the decreased toe grip strength, decreased compared to what? As far as, how are they measuring that? What are they looking at? So that was one part of it. The second part of it is a lot of times people will attribute, or I've seen it attributed, Hallux valgus to a weak abductor hallucis muscle.
Sure.
And where that may be true, if you look at the cadaver studies and the studies that are out there about the abductor hallucis, most of the time it's more of a flexor because it's actually around the toe. It's not actually on the side of the toe, but more of it occurs on the bottom. So it's actually more of a toe flexor than it is a toe abductor. And if you rotate the axis of that muscle around and make it a toe flexor, it's also going to pull the toe into somewhat more of a Hallux valgus type posture because of that. So, yeah, I don't know. And the other thing that I didn't see if they did, and I've got the publication up here, it's out of the Clinical Research in Foot and Ankle. As far as were they differentiating long flexors from short flexors. And it looks like to me, from the device that they were using in there, that they're using a toe grip dynamometer, which is going to measure only long flexor strength, not short flexor strength. Your short flexors go to your proximal phalanx, your long flexors go to your distal phalanx, your lumbricals go to your middle phalanx, pretty much over, touching into the hoods in that area there. So effectively what they're saying is people that had decreased long flexor strength, that I shouldn't say that they had it, it was correlated with increased amounts of Hallux abducto valgus. So it's an interesting concept with the entire thing, and it sort of flies in the face of the whole Abductor Hallucis, because I was always under the impression, and maybe wrongly so, but bunions occur largely because you can't anchor the base of the head of the first metatarsal, and because the Abductor Hallucis attaches, in that area there. If that base is not anchored, then rather than using that as the anchor point and assisting in supination and formation of the transverse metatarsal arch, it actually acts as an abductor of the big toe. And we see this in people with forefoot supinatus as well as people with true forefoot varices as well. So I was always thinking it was an issue with being able to descend the foot to a greater degree. And this sort of flies in the face of that.
Yeah, it certainly always brings to light my thoughts of how many people use towel scrunches and picking up pencils and marbles, which a lot of that is long flexor. And I'm always like, oof, man, most people are too flexor dominant as it is. And if someone has a Hallux valgus, and they've got a long flexor activation, you will see that valgus actually increase. At least that's my experience, and the rotation will increase. You'll see that big toe literally go more west or east depending on which foot it's on, and it'll spin a little bit more. And most people don't have enough short flexor and long extensor, hence why we see so many people with a slight or an aggressive curl to their toes. And so, I agree with you. We need more extension, long extension. We need more short flexor, and we need more abduction. And that's that whole lift, reach, and spread that you tagged. And I think if people would spend more time doing that than using toe spacing type devices and doing towel crunches and stuff like that, which is a big staple for a lot of the therapy that's out there for foot problems, because we think that's what makes our foot strong, I think they'd do a lot better. I'm not saying those other things don't have value, but you need to actually find someone who actually has documentable long toe flexor weakness in order to give that as homework. And I don't know how strong I would agree with this article on the correlation between those two, or at least causation maybe is a better way of putting it. So interesting nonetheless, though. In other words, you got to know what you got in your client, and you have to know how to address it. And you can't just take a study like this and postage stamp it on your client saying, oh, you've got a bunion, you need more long toe flexor strength, or you've got weak toe flexor strength, we need to protect your bunion. I think that's overreach for this article, but who knows? May work for some people. I don't know.
Right. Well, they do talk about in the article how toe grip strength is important for push-off phase of gait. And when you look at the EMG charts, those guys are firing from mid-stance through pre-swing. I mean, that's their job. I don't think they have as much of a propulsive component as they do trying to keep the foot as a rigid lever in supination, pushing forward and ensuring that those forces are transmitted to the first metatarsal. So, interesting, nonetheless.
Yep. All right, man. Good podcast. That was fun. It's always amazing how quickly an hour goes.
That it is. Yeah. But it was good, and we've got more goodies for you in store down the road. But
you put up some great stuff on the new Ultra shoes, the trail running shoes. Man, I even wrote the company and I said, boy, I'd really like a pair of your shoes. I'm willing to take a picture and put it on our Facebook page if you send me a pair, because I'm such a cheap bugger. But if they don't send them, I'm buying a pair.
They're sweet, and it's actually a hiking boot.
Yeah.
Yeah, they really are. We're talking about the new Lone Peak 3.0 Mid, which is basically a light hiker. So it's the Lone Peak platform with a stronger heel counter, a little bit more torsional rigidity, and an over the malleoli type cuff, which overlays that. It's an awesome shoe. I remember when we got them in. But yeah, they are flying out the door, literally being in Colorado, hiking central here, and I see myself snowshoeing and snow biking in those this winter. And they're also, it's not Gore-Tex. They have their own proprietary fabric, and the name of it's slipping my mind at the time. But they are waterproof as well. Now, I haven't tested that, walked through streams and things like that, because that's why, well, it's funny. So one of our reps came in today, and he's got a new sock line. And we won't talk about it on this particular one, but we can talk about it on another one because I haven't tried them out. But whenever they give us samples, we give everything the abuse test. It's like, okay, so new socks, these are supposed to be guaranteed for life. So I'm going to just wear them, out into the driveway, walking around property, doing stuff. And we encourage our staff to do it as well whenever we get new product in the office, because we really want to test it. And if we're going to sell it in the office, we want to say, hey, look, we use this stuff. We can tell you that it is good or it's not good, or the longevity. And that's why we stopped carrying certain brands in the office and started carrying other ones. One, either because of their warranty, or two, because of their durability and name. But anyway, I can say that this company, and you could look them up, they do have a proprietary double layer sock with an inner liner in the sock, and they're guaranteed to be blister free.
Wow.
Yeah, so we're putting that to the test. I've got a pair in my briefcase that I brought home from the rep. He gives, we're pretty good customers, so he gives us lots of sample stuff to try out and take out. So I told him that we would go to abusing them pretty immediately, and then give him a report back. But it's looking good. They're mostly poly pro, but they have a merino wool line, which we're particularly interested in because we're big merino wool people.
Yeah, very cool. Can't wait to hear about it.
It'll be good. Maybe next podcast we could talk about them. So,
sounds good. All right, folks. Enough nonsense. Get on with your day. I'm Sean Allen in Chicago.
I have a whirl up in Dillon, Colorado. We will see you in the shoe aisle.